Next, we have Dr. Vanathi ma'am presenting topical human immunoglobulin as adjunct therapy in refractory dry eye disease.
Thank you. So, topical human immunoglobulin as an adjunct therapy in dry
Dr.
eye
Saab, can you
disease.
speak a little louder? Somehow it's not. Thank you.
Topical human immunoglobulin as adjunct therapy in dry eye disease. No financial interest here. I wish to acknowledge all my co-authors in this study here. Recent literature points towards the various pathological consequences which are available on the ocular surface, which are responsible for the refractory nature of the ocular surface disease in dry eye patients here. Of such, what we have identified is what is known as the ACPAs, or the anti-citrullinated protein antibodies in the tears of dry eye disease patients, which are responsible for the refractory dry eye disease nature, which does not respond to the conventional dry eye therapy in these patients here. So you have the phenomenon of netosis and you have the phenomenon of ACPAs, which contribute to ocular surface inflammatory mediators, and thereby these not being responsive to the normal therapy which is given in dry eye disease patients. The lacunae in literature is paucity of literature on the clinical response of dry eye disease to ocular surface immunoglobulin therapy here. So the aim of our study was to evaluate the role of topical human immunoglobulin, IgG eye drops, 4 milligrams per ml, as adjunct therapy in the eyes of moderate to severe dry eye disease patients. The study design was a prospective longitudinal interventional study done at RP Center, AIIMS, New Delhi, during the period ranging from April 21 to July 22. Sample population consisted of chronic dry eye disease patients with a minimum of 30 patients in cases and 30 as controls to be evaluated over a period of 6 months. And inclusion criteria was patients more than 18 years, TBUT less than 7 seconds, Schirmer's less than 9, ocular surface disease index above 13, and corneal and conjunctival staining scores of over 3 here. The exclusion criteria was as depicted here. The study commenced after institutional ethics clearance, and a clinical trial registration number was also taken. Informed consent was obtained from all study participants here. So we plan to recruit a minimum of 60 patients, so minimum 30 in the cases group which had dry eye therapy with adjunct therapy with topical immunoglobulin given twice daily, and the group receiving just conventional dry eye therapy remained as controls. Ocular surface evaluation dress in terms of TFOS due to grading. All the ocular surface evaluation parameters were done here. Topical human immunoglobulin 0.4% was reconstituted from commercially available IVIG drops here in our in-house pharmacy here. We also computed a treatment grading score to calculate the change in the severity or the need for potent topical steroids and the frequency for lubricant therapy in terms to objectify the efficacy of the treatment in our patients here. So this is the graphic representation of patients and of the controls and cases groups here. The age is equivocal. It was a gender and age matched study here. We had follow-up data of 53 eyes who were recruited for 6 months, 14 had completed over 6 months, 4 had been lost to follow-up here. So when you look at the characteristics of at baseline and characteristics at 3rd month, 6 months follow-up, all showed a statistically significant improvement in the OSDI scores, the TBUT, the Schirmer's, the corneal and conjunctival staining scores, along with the conjunctival hyperemia scores as well, as compared to the cases group here. So the controls group here. So this shows the box whiskers plot depiction of the various scores of the patients when they were being followed up at 3 months and 6 months, and this graphical representation clearly shows an improvement in the ocular surface evaluation parameters over a period of time. The improvement in the hyperemia scores in comparison to the cases and the controls is also depicted. These are clinical pictures of few of our patients or of the study participants in our case here. There was also a change in the treatment parameters of all the patients after we applied the scores here. So what we would like to highlight here is that the use of topical IVIG drops gives a significant benefit when given as an adjunct therapy and is effective in decreasing the ocular surface inflammatory mediators and giving you a better clinical response as compared to conventional clinical therapy here. The limitation is we would probably, a larger sample size would have been much better here, and also correlating it with the clinical response with evaluation of inflammatory mediator responses would also give more objectivity in terms of understanding how the inflammatory mediators change in response to IVIG drops. Wish to acknowledge all my coordinators in this clinical study here. Thank you for your patient hearing.
Thank you, Vanathi. Dry eye is always a very, very fascinating disease, and you all have brought out something very new. I just wanted to also check back that the group of patients whom you had chosen, were they, was there a specific etiological factor that you had found for the dry eyes?
Yes.
Was there any systemic cause for the dry eyes?
Most of the patients who were recruited in this were defined as chronic, moderate to dry eye disease patients here. They were by Sjogren's patients, ocular GVHD patients here, and patients secondary to rheumatoid dry eye disease here. So they
Okay.
all had a definite systemic association for a dry eye disease here, and we categorized them into two groups here. And the phenomena which are now being attributed to the refractory nature of dry eye disease in these patients is the phenomenon of what is known as the net traps, the extracellular nuclear traps which are present on the ocular surfaces, which are probably inducing inflammatory mediators, or also the ACPAs, the anti-citrullinated protein antibodies which are present on the surfaces. This is taken care of when we give IVIG drops. The ACPAs respond to the IVIG topical therapy, and we have found significant clinical improvement. A large chunk of our patients are ocular GVHD patients here who are really very severe dry eye disease which do not respond to conventional treatment.
Do you think would you like to have because so many of these patients with dry eyes on because of systemic problems, let's say for example like rheumatoid arthritis, we keep on treating the inflammatory element of it with cyclosporin. Do you think that this particular therapy that you'll have come with, because it's very difficult to formulate, then in that case, do you think that this will be more helpful than cyclosporin?
Yes, it did help. We did look at the change in the need for using immune mediators in these patients here, and the change in need for higher potency steroids, and the change in the frequency of steroids used and the lubricants used. So we gave an objective score for all of these, and all these had a clinical significant, statistically significant improvement when we had given them twice daily IVIG drops.
Yeah, the only thing is manufacturing.
Yeah.
And how that's the only, I think, difficulty. But thank you very much.